thank you very much for that kind introduction and for the invitation to present in this lecture series. It's a real privilege to have this opportunity. So I'd like to speak to you for about 20 minutes or so on the subject of the influence of framing on why some global health issues receive attention while others are neglected. This is a study that I undertook with my colleague Yusra Shawar, who's an assistant scientist at the Bloomberg School of Public Health at Johns Hopkins University. So what I'd like to do is first speak about the motivation for the talk, the study, then some background to this study, the findings, and then future implications. So let me start with a few comments to give you background and motivation for what this is all about. It's useful to begin with some puzzles in global health priority setting that illustrate the phenomena that we're interested in. So first, both cholera and Ebola are communicable diseases that spread across borders. Cholera historically having killed many more people than Ebola historically. But the World Health Organization has officially designated Ebola, but never cholera, as what is called a public health emergency of international concern, which thereby requires countries and governments legally to take action. Why this difference? Here's a second puzzle. Both HIV/AIDS and diabetes kill many people each year in low, middle, and high-income country settings. But there's been a powerful groundswell only to make antiretroviral drugs for HIV/AIDS, but never insulin for diabetes widely available across the world. Again, why do we see this difference? Third puzzle. In the 2000s, neglected tropical diseases, or NTDs for short, suddenly came to acquire billions of dollars in external funding and donor resources. Prior to 2000, that disease category, the concept of NTDs, didn't even exist. It was actually invented as a category. How did that happen? So these puzzles that I'm pointing to illustrate an important point, that there's obvious differences in the priority that global health issues receive. And social science research shows, I'm a social scientist, it shows that these differences are not fully explained by so-called rational factors that you might think would explain them. Rational factors such as, say, the number of deaths they cause, how quickly they spread across borders, whether there are effective and inexpensive interventions that exist. There's a great deal of speculation as to why we see these differences in priority levels across issues, but there's not a lot of systematic comparative research. So trying to explain these differences in attention, priority, the resources that global health issues receive is one of the reasons we undertook the study that I'm going to tell you about. Here's another reason we undertook this study. Numerous observers note that from an ethical perspective, global health priority setting is not done well. One concern is what a number of observers call the democratic deficit in global health priority setting, meaning that it's dominated by political leaders and elites of various kinds, but there's insufficient voice for at-risk populations who are most affected by the harmful conditions. A second reason is that it's noted as not being done well is that there's this unhelpful competition among global health issues for scarce resources and attention, leading to the prioritization of just a few and the crowding out of attention and resources for many others. So all these considerations led Yusra Shawar, my colleague, and I to a research agenda on how global health priorities form. And this study carves out a piece of that agenda, focusing on framing and elite preferences. And I'll say more about those concepts in a second. So what do we mean by framing? Well, there are many definitions of framing, but for the purpose of this study, we mean the way that political elites and publics understand and portray public issues. The interesting point is that on any issue can be framed in many different ways, and there's competition among groups to advance their preferred framings. So just to give an example, think about obesity. It has been framed as a medical or a genetic issue requiring medical interventions. It's been framed as an issue caused by poverty and lack of choice, requiring policies adopted by governments. It's been framed as a problem of individual behavior, requiring people to make better choices, or asking people to make better choices. Now, none of these framings of the issue are necessarily right or wrong, but they've all been advanced publicly by different groups, and they offer different portraits of the problem. So let me now turn to our core findings and just a bit about the methods we used for this analysis. So in a nutshell, I'm just gonna minimize the, oh, never mind. These are our core findings. So objective factors such as the transmissibility of a pathogen and the death it causes do indeed shape which issues get attention in global health. But there's far more to it than that. In particular, global health elites, meaning high-level government officials, officials in international organizations like the World Health Organization, prominent scientists, they have heavy influence on these priorities. And they use their power to frame issues in particular ways in order to secure attention and resources for the issues that concern them. And they do so especially through three framing processes. The first is what's called securitization, which is portraying an issue as a very serious threat to humanity, potentially an existential threat. And you can think of Ebola as having been framed in this way. The second is moralization, which is the portrayal of an issue as an ethical imperative. And here, think about how access to antiretroviral drugs for HIV/AIDS as an example. Third is technification. And this is the portrayal of an issue as a wise investment that can be solved by science. And here, NTDs, neglected tropical diseases, are an example. And it's not that these portrayals are inaccurate, but it's that they're portrayals. They're placed onto some issues, but not other issues that easily could be characterized in the same way. So to do this research, we undertook a particular kind of review of scholarship called interpretive synthesis. We reviewed about 130 works from the social sciences on global health policy making. And I'm happy to share in the question period more information on how we went about this review and derived our conclusions. Our study is grounded in a fundamental debate in the social sciences, and that is, what is the relative influence in policymaking of tangible, objective, measurable forces, such as how much death the virus causes, compared to what are called subjective forces, such as what I've been talking about, the framing of an issue as a threat, things you can't really touch, but they're in people's heads, they're in people's minds. So now let me turn to specific findings. So we reviewed more than 100 works on global health policymaking, and it revealed these three framing processes called securitization, moralization, and technification, and the power of these processes at work and how they help to explain how issues come to receive priority. Each involves a distinct combination of a dominant frame, a kind of actor, forms of power that are being used, and the motivations of these actors. So let me speak about each of these three processes in turn. So Ebola is one example of securitization. Another one is H1N1 or swine flu. The dominant framing for an issue that has been securitized is that it's a serious threat to humanity, potentially existential, that requires extraordinary action. These are issues that are perceived to be ones that cannot be left to the health sector alone. They require action at the highest level bodies in national governments and international organizations, even as high as the UN Security Council. In securitization, government leaders are commonly motivated by fear, and they use compulsory power, including threat of legal sanction, to get citizens to act in particular ways. So Ebola is the only disease that has twice received official WHO designation as a public health emergency of international concern. That designation has only been given 6 times in history, and it places a requirement, a legal requirement on governments across the world to act. The disease has inspired great fear about cross-national transmission, even though experts say such transmission is much less likely for this disease than many other diseases. An interesting dimension of securitization is that political scientists have found that only particular kinds of conditions are likely to be securitized. And this quote illustrates this point. I'll give you a moment to read it. So many political scientists, in other words, find that securitization is mostly, if not exclusively, about protecting rich countries from diseases they fear, and that diseases that have long been endemic only in poor countries are not likely to be securitized. So if securitization is about the framing of a condition as an existential threat, moralization is about its framing as an ethical imperative. Access to antiretroviral drugs for HIV treatment is an example of this. Reproductive health is another issue that's been moralized. And here, often the primary actors are civil society networks, often allied with governments and international organizations. For instance, organizations like Doctors Without Borders join with other organizations to lead global campaigns on a health issue. And they're often motivated by indignation at the injustices in society, and they use the power of principled ideas to mobilize action through global movements. There's considerable evidence to indicate that ARVs have emerged as what's called a global merit good, meaning there's an expectation that has emerged that they should be made available regardless of ability to pay. That is, the idea that just because you're poor and can't afford the drug, that does not mean you should be denied access to treatment. And part of this shift is due to grassroots mobilization, such as that by the Treatment Action Campaign in South Africa. Part of this also is due to leadership by political leaders and elites like Peter Piot, who was the former head of UN AIDS, which is the UN agency that focuses on AIDS. This quote by 2 political scientists studying the success of the global ARV movement on AIDS illustrates some of the elite and grassroots political dynamics at work. So you can just take a moment to read that. The interesting point here, which I'll come back to, is that there's only been a handful of diseases that have been effectively moralized, when in fact many, many diseases potentially could be. So the third framing process that we identified is what's called technification. And technification differs from securitization and moralization. It's not about portraying an issue as an existential threat or an ethical concern, although these frames may be part of an argument for prioritizing an issue. The dominant framing here is that addressing the issue as a wise, cost-effective investment, because the scientific means allegedly exist to solve it. Commonly, the dominant actors here are experts, scientists, economists, and others, and they're in research institutions or as well as in governments and international organizations. And they deploy power that they wield by virtue of their expertise to get governments to act. They don't usually think of themselves in this way as exerting power. They tend to rather speak of themselves as simply providing evidence. But many social scientists understand them quite differently. They're exercising power they hold by virtue of their authority, that comes from their expertise. So neglected tropical diseases, or NTDs, is an example of an issue that has been technologized. Interestingly, as I said, this disease category did not exist until the 2000s. And many of the diseases in it have very little in common to one another from a biological perspective. But once scientists invented this category, it took off and it garnered billions of dollars in funding. This is a quote by a scholar who studied the NTD initiative, and it illustrates some of the dynamics that were at work. I'll give you a second to read this. So the main dynamic here was that a small number of well-respected scientists, realizing that they were not going to get political action on these less well-known diseases, especially given the dominance of the big three diseases, namely AIDS, malaria, and TB. They weren't going to get action unless they brought all these smaller diseases together. So they invented the category of NTDs, and they used the authority they held by virtue of their expertise to get donors to provide funding and governments to act. So at first glance, one might say, well, of course, Ebola should have been securitized. Of course, antiretroviral drugs should have been moralized. Of course, NTDs should have been technologized. And a good case can be made that these framing processes were valuable and that the elites who stood behind these processes did work that benefited humanity. But it's also important to note that these processes were historically contingent. That is, there was nothing inevitable about their gaining priority or being framed in these ways. And if you compare across conditions, that sheds some light on this point. So I started with puzzles, right? Why priority for Ebola, but not cholera? Why for ARVs for HIV/AIDS, but not insulin for diabetes? How come NTDs suddenly get traction from the 2000s on, but other conditions similar in scope and severity did not? The interesting point is that these conditions, the nature of these conditions, inherent features of these conditions, like the number of deaths they cause, the speed of transmissibility, that does not provide a full explanation to understand these puzzles. We have to look at these subjective framing processes that I've just described in order to make sense of why we see these differential levels of priority across issues. So let me reiterate the argument before concluding with a couple quick implications. Global health priorities, the ones that rise to attention and receive resources, this is not inevitable. They're contingent, they're historically contingent processes. And while not the only influence, priorities are shaped heavily by elites, political leaders of various kinds, in government, international organizations, scientific institutions, as they exert power to enact their preferences and make sure that the conditions that they're most concerned about get resources. Now, of course, this input is essential. We need this expertise. But from the perspective of democratic theory and democratic representation, and if you believe that those affected by a problem have a right to voice in the selection of issues for priority, this dominance by a small group of political elites is concerning. So let me just conclude this with a couple questions and implications on how we generate more just, fairer global health priority setting. And I pose these for deliberation to all of you to think about. One is, how do we surmount this problem of narrow disease-specific advocacy groups in constant competition with one another for scarce resources, in order that we might try to promote a more unified agenda? Perhaps there's a need for some of the more powerful of these groups to act with a bit more caution, so that their advocacy doesn't have the unintended effect of harming priority for other health issues equally serious, but that lack advocacy groups or powerful advocacy groups. The second big question I throw out there is, how do we address the power imbalances in global health, at the same time preserving the necessary space for elite input and expertise? That is, how do we get greater democratic deliberation, more space for those most affected by the conditions to have voice with respect to which issues get priority? And I'm sure people listening today have plenty of thoughts and ideas and responses to these questions. So I throw them out there to you. I'll end this talk on these questions, and I look forward to your own comments and thoughts, and hearing what ideas you have about how we generate better global health priority setting. So with that, let me turn this over, and I look forward to your questions and comments.
Thank you. Hi, I'm Ishita. I'm a rising senior from New Jersey. Thank you for the presentation. I found it really interesting. My question was, so you asked us what ways that we could address some of these issues, what thoughts we have. I was going along the idea of educating the public more, but with that idea, my question is, would that even help? If we try to make the information about global health issues and certain diseases more objective, if we try to present the facts to the public, would that carry any significant changes in the way that global threats are labeled on like a more macro level?
That's a great question. How about if we take 3 or 4 at once, and then I can do another round that might enable more people to get their questions in.
My name is Tassine. I'm a rising junior from Virginia. And my question was, do you think societal views or certain taboo topics in different cultures may affect how global health priorities are placed? Like, do you think these societal views positively impact the priority placed on those issues or negatively?
Thank you for that informative presentation. I was just wondering, as someone who's interested in the intersections of policymaking and global health, what specific resources would you recommend? And then another question I had specifically regarding your talk is, do you think there would be any benefit to increasing education and trying to prevent doctor shortages in like areas in the global south, which could allow for more scientific appeal from the areas that are affected by these diseases?
Great. Why don't I offer a few comments on those 3 questions, and then we can move to another round. So thank you, Ishita, I hope, and Tassim and Sahil, I hope I'm saying your names correctly. Those are very thoughtful, well-informed questions by all of you. Ishita was asking about how educating the public might help offering more objective facts to the public. It would help. Absolutely, and this is something that we public health folk absolutely have to do as a mission, right, to get the evidence out there. But we shouldn't exaggerate the extent to which it would help, because it's the evidence. I often tell biomedical audiences that the presumption that evidence is enough to generate priority is not supported by the evidence. In other words, these are political processes influenced in part by evidence, but also by other factors. And that really connects with what Tahsin's point about societal views. How do they influence priority setting positively or negatively? Well, you can speak to some ways in which they positively affect priorities, some ways negatively, but the point is that social views, cultural values also shape which issues get attention and whether the political system will prioritize an issue or not. Just think about reproductive health, the abortion debates and so forth. These feed into deeply held cultural belief systems that constrain and affect the political system and what can and cannot be accomplished. So it's not just evidence, it's also culture and social values that are shaping these policy processes. And Sahil, I'm happy, perhaps I can share after the talk with Siam and others some good resources on health policy making that you might be interested in so that everybody can take advantage of these works that I would recommend all of you read if you want, especially if you want to know about global governance of health and health policy making in low and middle income countries, which are the two areas that I work on especially. And yes, increasing education, doctor shortages is a critical issue. You know, I'm sure many of you have heard about problems of brain drain and medical professionals moving away from lower income countries to higher income countries, and something has to be done about that. It's quite an unfortunate problem. So thank you for your question.
I'm Jada Yang. I'm a rising junior from Los Angeles, and I was wondering about the same kind of topic as some other questions that were asked about social views or like stigmas around certain topics. And so do you think there's any hope for like calls to change those types of social views through like advocacy groups, like you said, and like issues that were less talked about? And if so, how would those groups go about doing that?
My question is, do you think the control to addressing the discrepancies in disease funding lies in the powerful politicians or the general public?
Let me see if I can say a comment or two on each one. Jada asked about social views. How much can these change? How do we do so? Can advocacy groups do so? Jada, it's interesting to think about social belief systems as at different levels. Some beliefs are so deeply ingrained that it becomes very difficult to change. And I'll give you an example. If you consider yourself a conservative, it's very tough to just have someone talk with you and you suddenly become a liberal. And vice versa, right? These are deeply ingrained belief systems that don't easily respond and change overnight. But there are other beliefs that do actually respond more to evidence, not ones deeply, deeply ingrained. Like if I tell you this is going to work to treat TB, not that, and I present you with evidence, you're more likely, if you're scientifically minded, to change your belief. So it depends. The degree of malleability of social belief systems depends on the degree to which they're deeply embedded. Psychologists study this, so interesting question. Tiki, you were asking, could you repeat your question? You were asking about global leaders ignoring malaria?
My question was about, do you think—
Oh no, sorry, Tiki, not Vicky, I got yours, Tiki, the question before you.
Hi.
Yeah.
So not just specifically malaria, but I was wondering what role you think global health leaders play in addressing diseases that are more prevalent in developing countries and largely ignored by the rest of the world.
Oh, right. Okay. Well, there is a big problem that it's much easier to generate resources and attention for diseases that afflict rich countries. This is a huge problem. But over the past 25 years or so, a whole set of global governing institutions, everything from UNAIDS to the Global Fund to Fight AIDS, Tuberculosis, and Malaria to Gavi, the Vaccine Alliance, and parts of the WHO, parts of the World Bank, all these international organizations and private philanthropic foundations like the Gates Foundation have been devoting more and more resources to addressing the conditions that affect low and middle income countries. So this is a positive development. It is possible to move the needle here, but we haven't gone nearly far enough. So I think that's the main point. And Vicky asked about this, how do we get funding for neglected issues? Is it more contingent on the powerful elites or the public, mass publics? That's an interesting issue. And yes is my answer. You see, it depends both on grassroots mobilization as well as top-level political action. The primary example of grassroots mobilization to get an issue on global health agendas, the primary case is AIDS. There you saw mobilization in places like US and Thailand and Senegal and South Africa and Brazil, where civil society groups demanded justice. But sadly, there aren't a lot of cases in global health where you see that happen. And often if an issue gets priority, it's not because of that process. It's because political elites decided, often in a well-meaning way, that an issue deserves attention. So we hope for more grassroots mobilization, but they're not mutually exclusive. There are multiple paths to the ascendance of issues in global health. So maybe we can go to the next round.
Hello, good afternoon. I'm sorry, I don't have a camera. My name is Ilya. I'm a rising senior from Georgia. And now I had a question. Do you think social media becoming more widespread allows for medical issues to be more noticed and discussed around the world, or does it just lead to more clutter and medical misinformation? And which is better for the world, kind of?
Hi, Dr. Shiffman. Thank you for your presentation. My question was regarding if it would be more beneficial to give more financial power and more, say, administrative power to lower level officials like state or provincial officials in terms of deciding where their resources should go to whatever diseases or health issues are more prevalent in their area, rather than assigning it to, say, global organizations like the UN.
Hi, Dr. Shiffman. First of all, thank you so much. It's really been an honor for all of us to get to hear your presentation. And my question kind of regards to what we as like young and aspiring global health leaders can do at our different scales, because I know that we can influence our community, but how do you think we can kind of grow past that at our age? For example, I'm a rising junior in Nicaragua, and I just kind of want to know what I can do, to get really involved and how far into this kind of advocacy and like information for other people I can get into apart from, educating myself. Thanks.
Great, thank you, Ilya, Stephen, and Maite for these great thoughts and questions. Ilya asked about social media, useful or clutter. I think in terms of the study of global health advocacy and priority setting, this is a huge issue that we don't know much about. I mean, it's pretty obvious that in social media, there's a lot of misinformation, clutter, harmful information out there. I mean, look at the COVID, all the misinformation about COVID vaccines. It's really awful. But it's also a forum, Twitter and elsewhere, to get good information out there. I suspect it's a mixed bag. In fact, I'm pretty sure it's a mixed bag. But we don't yet have a lot of studies about the effects. And especially, I've seen very little research on the effects in terms of which issues ultimately get global attention in health, the effects of social media on that. So I'm sort of suggesting that you raise a great question that we need to study much more carefully. So Stephen, this is a really interesting question, whether we think it's better if lower level officials closer to the ground rather than big international organization officials at the top should have more power in deciding priorities. I think, and many of us in the global health field think absolutely they should have more power, that there's too much power concentrated at the pinnacle of these international organizations by people who are too far removed from the realities on the ground, that there's what I called in my talk a problem of democratic deficit, and that people know their realities, they know their problems, and they need greater voice in global health priority setting processes. That being said, I don't want to go overboard with this because many elites, scientists and others, leaders of international organizations, are very well-trained, well-meaning folk who have a lot of knowledge to offer, and that should not be discarded. But in the balance of power is too much at the top. So you raise a hugely important question. And Maite, what can young people do? You're in Nicaragua. That's inspiring, and actually it's really inspiring to see just how many people have come to this forum to listen to these. I'm just, for me, as someone who's been in the global health field and just seeing hundreds of you interested in this stuff, it's so exciting. I have a son who's 16. Probably many of you are in that age group, and it's just exciting to see the cohort that is engaging this. Well, what can you do? Maybe there are local advocacy groups, local NGOs that you can volunteer for and learn a little bit more about the world of global health. Maybe you can get on social media in a positive way and share not misinformation. Don't do that. Absolutely. But evidence-based studies and reach your colleagues, reach your friends. And then maybe, you can do as Siam and others have done in college, study public health as a major, or take global health classes, volunteer when you're at university, and this will lead you to many opportunities. This is really, global health is such an exciting field. It's a growing field. The COVID pandemic, it's been horrible, but in terms of interest in global health, it's at my school of public health, we have so many students we can hardly serve them well, which is a good thing that we're getting so much interest. So I think there's a lot of opportunity in this field. I encourage you all to stick with it.
Hi, Dr. Shiffman. Thank you so much for the wonderful presentation. I'm a rising senior in Northern Virginia. There is this new movement regarding the decolonization of global health, which wants to, basically take a post-colonial perspective at the research and practice of global health, like an area that has been redefined by contemporary scholars and advocates with the purpose of promoting equity and justice. And I was wondering if that may play a significant role in implementing new healthcare beliefs within communities and destigmatizing certain modern medical practices in developing countries.
Hello, Dr. Shiffman. Thank you. And going back to the democratic deficit, what should people living in the U.S. Expect with the Supreme Court ruling over limiting the environmental protection agencies' ability to oversee environmental challenges?
Thank you for these two questions. Kritika, yeah, I'm glad you raised decolonizing global health. It's a major phenomena emergent in the past few years that understands the whole field of global health to have emerged from unfortunate colonial origins, centered on protecting the interests of European powers, not with humanitarian cosmopolitan imperatives, but self-interest at heart, and that these practices perpetuate themselves within the global health field with many adverse effects. And these folk are seeking to overturn power structures and change the field. What effects are these going to have? We've actually been doing some studies. I think it's too early to tell, to be fully honest. You know, those centrally involved in decolonizing global health say they're involved in a movement.
Yeah, I think that's the new definition as of now.
Right, right. It's too new to tell. I mean, it certainly isn't a movement of the size of the AIDS movement, even remotely. The AIDS was a movement. AIDS really transformed global health. AIDS changed the way in which we view the antiretroviral drugs to one that people deserve to have regardless of ability to pay. Will decolonizing global health change the field, alter practices deeply, or will it encounter power structures that are too entrenched?
What are your personal thoughts on it? Because I feel like it's definitely going to be politicized in the near future. It's going to be more of a political thing than anything, in my opinion.
Yeah, well, okay, so I'm in the School of Public Health and I see this, students want to learn more about it. And it's a greater and greater interest. I'm glad it exists. I should also say that any movement, any new set of ideas should not be immune from critical scrutiny. Nothing should. And so there will come a time when we have to look at decolonizing global health and look at it with the same critical scrutiny that it looks at the world of global health. And we'll just have to see where it goes. It has some powerful, valid ideas, but you also have to ask who exactly are the people promoting it. I'll just give you an example. We did a study and we did surveys of folk, including many health actors in low and middle income countries. Many of them had never heard of it. It's an interesting phenomenon. So you have to ask, where is this coming from? Who's promoting it? What is its power? What is its value? And if we were to critically scrutinize it, what questions would we ask as well?
So it's still very fresh.
It's fresh. We don't yet know what to make of it, but I'm glad you raised that.
Yeah, thank you so much.
And Daniel, yeah, interesting. The democratic deficit. What do we expect from the Supreme Court limiting the power of the EPA to oversee environmental changes? Well, I mean, I'm not a legal expert. I'm not a U.S. focused person. I'm a U.S. citizen, but I don't study the U.S. But you got to think this isn't very good for climate change, for U.S. contribution to climate change, for protecting the environment, for the capacity of government to enact pro-health regulations, pro-environment regulations. This does not seem to be a positive trend. I don't have too much more to say about it than that because I don't particularly study this issue, but it does seem to be quite in my opinion, quite an unfortunate development.
Thank you.
Thank you. And if there are no more questions in the last few minutes we have, Dr. Shiffman, we have a lot of students who are still sort of considering a career in global health or medicine, and a lot of students have sort of these multidisciplinary or intersectional approaches or interests. Could you just tell us a bit about sort of how you ended up in this interesting space between international studies and global health and public health, and basically what got you to the work you're doing today?
Sure, I'm happy to share a few thoughts on that. I think the first thing I'll say is I'll repeat that I'm so pleased to see so many of you interested in this subject, because when I was in high school, I hadn't even thought even remotely about this field. So, I don't know what I was thinking back then, but I wasn't engaged in international or global health. I think what brought me into it was, actually, maybe I should clarify exactly where I see my niche. I'm not a medical professional. I never trained in the biomedical sciences. I don't have an MD. I don't even have a master's in public health. I never studied public health. I got my PhD in political science. And then I discovered that a really interesting angle in this field, which is dominated by biomedical professionals, which is great. To have doctors, biomedical professionals is absolutely what we need. But my niche is not there. It's as a social scientist. I use political science, social sciences to analyze this field. And my interest isn't so much in specific interventions or immunizations, it's in power dynamics. And I throw this out to you all by suggesting that while I suspect, and please go forth with this, many of you will end up doctors or health professionals. Maybe some of you might say, well, instead, I want to take a different angle. I'm going to train as an anthropologist or a political scientist or a sociologist and understand society and use it, or economics, and understand the world of global health through that kind of lens. And I'm telling you, it's a very interesting and different lens, and it's the path that I took. And I've found that it's allowed me to engage in the world in global health in a very different way by asking questions that I asked today, like why do some issues get attention but others don't? As opposed to discover, how do I discover the next vaccine, which is of course very important, but that's not what I'm trained to do. So it's this different angle that I came to almost randomly. I just got interested in it after my PhD, and I wanted to use my political science to study something I cared about concerning social justice, and that happened to be health. So that's kind of how I came to it. And I'm hoping that some of you may in the future discover a similar path. Maybe combine an MD with a PhD in anthropology or sociology. That's another thing to consider in your future after college.